Okay. All right. Bye.
Trying to figure out how to mute myself on this thing.
Eye makeup. I don't know what I must tell you. Are you plucking on?
This is all the games. That's why it's got like.
Hi, everyone. This is Dr. Lisa Faille. I hope you can hear me okay. Can I see a thumbs up from everyone who can hear me? Oh, maybe I'm on mute. Can anybody hear?
Lisa, this is Dr. Brown, and I can hear you fine.
Oh, great. Okay, great. Thank you, Mary. I appreciate the thumbs up. And thank you for letting me know, Dr. Brown. Okay. Oh, I get all thumbs up in the chat. Awesome. Thank you, everyone. So, Dr. Brown, might you know how I would go ahead and start sharing my screen to get my presentation up?
Yes, they should give you presenter rights. Who's the monitor in this room?
I'm right here, Zainab Musa.
Hi. Hi, nice to meet you.
Hello.
I'm Dr. Faille. Hi. All right, I'm ready whenever you are.
Okay. So hello everyone. My name is Zainab Musa. I will be your room monitor for the presentation. And then if you guys can all mute, just so we don't have too much static. And if you have any questions, we're gonna take end from the presenter. And then of course, they said that to make sure any students of the Chicago, make sure that your first and last name are shown because we're gonna take attendance. And then I will pass it to the presenter. Do I have to do anything for you, or do you got this for the presenter?
You may need to go up into the right corner of her screen or to the participants at the bottom and click that and give her presenter rights.
Okay, so I see that I can mute, pin a video, make a host.
Yes,
make her
a host.
Okay. Sorry.
Not a problem.
You know, I didn't know how to do it either, so it's all good. It's all good. We'll get there.
I think I made you the host.
Okay. All right. Can everyone or anyone see my screen?
Not yet. We can see you.
You see me. Okay.
Yes. Yeah. You'll have to run your cursor down to the bottom of your screen where it says share and click on the share.
Aha. Okay, how's that? Can you see my screen now?
Yes.
Oh, great. I thank you both, Dr. Stower and Dr. Brown, for your patient guidance. All right, let's see if I can get this to full slideshow view. And I thank all of the audience, first and foremost, for your patience as well. It's just a little bit after 1, so we will go ahead and get started. So I was able to collaborate on this presentation with several wonderful students, Joy, Tanya, Lauren Bennett, Angela Fielder, and Shirley Leo. And it was such a pleasure to work with all of them on this. So without further ado, let's get to our topic of reducing mental health stigma for childhood victims of trauma. So let's talk about childhood trauma, specifically adverse childhood experiences. also referred to as ACEs. ACEs was a term developed in the late 90s, roughly just before the turn of the century, and it refers to potentially traumatic events that can negatively affect children. And that can include everything from household challenges to abuse, neglect. Household challenges might be something like having a sibling with a severe disorder, or having a parent with mental health issues, or something like homelessness. There's a high prevalence rate for ACEs. 12.5% of participants in just kind of a random sample reported an ACEs score of 4 or more. And I need to move this over. And 64% reported a score of at least a 1. 1 refers to any type of childhood traumatic event. And again, not all childhood trauma is abuse, but certainly a good portion of it is. And then when they look at a mental health residential center, 95% of the patients reported at least 1 ACE. Wow. That number really struck me, because that's high. That is high. Now we want to, point out, of course, correlation is not causation. It doesn't mean that directly caused it, but there's a relationship there that warrants further explanation for sure. So let's look at the effects of these adverse childhood experiences. When they happen in childhood, they're associated with, later on, increased likelihood of smoking, substance use, alcohol, just in general, lower ratings on quality of life, and even medical conditions with respiratory issues and digestive problems. We know from other research about the strong correlation between mental health and physical health, and that certainly is no exception in terms of ACEs and health later on.
Wearing masks. For you to go out and about, you have to be wearing a mask now.
Hi, everyone. Please make sure that you're muted so Lisa can go on with her presentation. Thank you so much.
Thank you. And then mental health issues later on are certainly associated with adverse childhood experiences as well, and also comorbidity of substance use and mental health issues later on. And those two, when they work together in tandem, really can be very, very debilitating for an individual. So the relationship between early adverse childhood experiences and risk later on has been found as well. Exposure to an adverse child event in early formative years also affects how we think. It affects our cognitive functioning, especially our executive functioning. Executive functioning, that's the part right up here in your, right behind your forehead, where it's the part of your brain that makes all the good decisions, is very logical, rational, can even process complex emotions like ambivalence, and other difficult life decisions. That all happens right up here in your orbital frontal cortex and that executive functioning. And it's mostly about your good judgment about, I was working with a client once, and he said his wife was mad at him. I said, why? He said, because I lost $1,200 gambling. Well, given how long and hard it takes both of you to earn that money, the executive functioning to see that as too great of a risk for your level of income and financial security, that's executive functioning. He actually did have some early exposure to trauma. And the distorted stress response. So this one is something I really want to take a minute on to explain. We've all heard of the fight or flight. Sometimes it's now newly referred to as fight, flight, or freeze. You might have heard those three as well. And so the stress response, that's a needed part of our body. We have survived as a species, Homo sapiens, throughout tens of thousands of years because we have had a stress response. So for example, I won't take too long on this, but let's go back to the days of the cave people. Way, way back then, if you think about what it was like for them, well, in those days when, we're still developing very, very early Homo sapiens, maybe even early Neanderthal and so forth, they were kind of figuring out how to handle stress, how to respond, even develop their amygdala and anxiety. So when some of them saw a fierce predator, they did not run. They didn't have a developed enough amygdala to produce the anxiety to be afraid to run. So those people the ones who did not run when they saw the predator, well, guess what happened? They became lunch. So they did not pass on their genes as often as the people who saw the predator and said, oh, wait a minute, I saw the predator, eat this other animal. Maybe it would eat me. Maybe I'd better try to, run and hide in the cave. So the people who saw it got a stress response, saw the fearful predator, got a stress response, ran in response and hid out of fear. They survived. They passed on those genes. So we have those genes. We are essentially biologically pre-programmed to respond to stress with anxiety, with fear, and whether we do fight, flight, or freeze. Can everyone just make sure you're on mute? I hear some coughing. So if whichever one we do, and the fight, flight, or freeze, they're all rooted in fear. People respond to fear in different ways. But that fight, flight, or freeze response in children who have undergone trauma, particularly physical trauma like abuse, they have a really hard time differentiating between the types of trauma. So the trauma that they experienced as children where they where they were hit, yelled at for, okay, you spilled the milk, and then they got yelled at severely or hit or thrown or, all kinds of things. Some red ink appeared on the page. I don't know how that happened. It wasn't me. It wasn't my kids. I don't know if anyone else can see that. It doesn't matter. So when the kids, when they were younger, they got yelled at for, maybe something small and got severely beaten. Well, then later on, when those kids are at a store or at work and they experience a stressful situation, they tend to kind of get it mixed up with the stress they experienced as children. And so they're trying to return something at the store, and the return clerk says, the store clerk says, I'm sorry, your receipt is past the expiration date. Well, they become frustrated, and it's hard for them to differentiate that frustration from the same frustration that they felt when they were a little kid and they were getting beaten. It all gets kind of mixed up in there for them. So then they start to get as upset as they did when they were getting beaten as a little kid. And that's why you see somebody yelling in a store because, all that happened was the clerk said, no, I'm sorry, I can't accept your return. But for that person, because of their early childhood adverse experiences, they're getting it all confused because that stress response is just reminding them of the same type of stress that they had as a little kid. Same thing when that person is at work and they're trying to work on a project with someone and their team says, no, I don't think we're going to go with that idea. And they get really upset because they feel that same frustration that they felt when they were a kid experiencing an adverse childhood experience, more than likely abuse. And they can't kind of parse that out. So that's what that distorted stress response means. So you can really see how it's not just, you know, the past is in the past. And when I hear clinicians in training say that, oh, the past is in the past, I think, no, it's still very much ingrained in terms of the stress response for people who've undergone trauma, particularly abuse. So I spent a lot of time on that bullet point, but that was merited a little more explanation. So the depressive disorders that happens as well. And the one that is most concerning, the suicidal ideation and attempts. People who experience ACEs are more likely to have those. That's always something to be very cognizant of as a clinician, because we don't want to see that. That's always a concern. So the impact of chronic on children and their caregivers, because we're going to talk about their caregivers, the parents as well. Trauma rates, when you look at poor inner city neighborhoods, 70 to 100%. That's high. I mean, just take a moment to let that sink in. That's a lot. I mean, and again, this was just a study of, a population in an inner city neighborhood, and 70 to 100%. I mean, I would think it would be something like 70 to 100% of residents reported being trauma-free. That would make more sense in terms of what just myself, in day-to-day life would be thinking. So not only is the trauma there, I think that most people, and again, I'm a psychologist, I consider myself informed, and I was truly shocked by this. So it's not happening, but it's a secret. It's not well known, and the secrecy around trauma, I could probably give a whole presentation on that. That's a whole nother area. And then the trauma reactions, the hypervigilance, always looking around, stranger anxiety, irritability, aggression, increased need for affection, support, and reassurance, which is hard to get when you're a child and your parent is in the same traumatic, stressful situation, whether it's in the family, the community. The hypervigilance one, it was, I worked in a juvenile detention facility, and I was a therapist there. It was a milieu program, a great program. We did a lot of good work, but I learned so much about trauma there because all of the juveniles there had experienced some degree of trauma. And for the hypervigilance, the interpretations they would make, we'd put up some Halloween decorations and there was a pumpkin that the mouth kind of lit up a little bit. And one, I guess it surprised one of the residents, and he said, oh my gosh, I thought fire was coming out at me. And it was, it didn't really look like fire, but I think when you have undergone trauma, kind of, you're more likely to interpret most things as kind of something to be afraid of, because there were so many things previously to really be afraid of. Or another time, they were out playing basketball, and some, I don't know what type of bird, probably some crows, flew over the basketball court, and they, because of where the sun was and the shadow, they really made, looked a little bigger than they were or something, and they were flying quickly. And one of the residents kind of ducked and said, oh my gosh, I thought somebody was throwing rocks at us. And I just thought, but they're birds. And it's just, when someone has gone through trauma, that hypervigilance is always there, even when interpreting birds flying over. Even birds flying over can look like danger to a child who's undergone early trauma. And then parents with trauma-related stress have a harder time parenting. So then how do you give the child the added affection, support, and reassurance, or even, maybe not forget about the added affection, support, and reassurance. How do you just give kind of the usual needed amount, never mind the extra? And also chronic stress, poverty, and violence is related to chaos within the family, disorganization, and just instability in a lot of ways. Instability emotionally, instability in terms of sometimes jobs, housing, relationships. So it's just multi-layered in terms of the impact. Parents in trauma. We know that there are transgenerational effects of trauma. They've studied offspring of Holocaust survivors. Not only did those children who grew up as children of Holocaust survivors, they were dealing with the effects of their parents and their parents' tremendous fears as their parents tried to survive and live post-Holocaust. So they endured that while growing up, and then also some of those children experience traumatic stress by the mother while in utero, even when the child was not in utero during the actual Holocaust. So in other words, all the stress that the Holocaust survivors felt didn't just go away once the Holocaust ended, and it stayed there, and that can be passed on to generations long after the Holocaust has ended, both by in utero and by the environment, by the way that those parents nurtured their children. I can only imagine the level of anxiety it must make a parent who's a Holocaust survivor. That parental distress transfers to children. It can also create what are called repressive patterns. And repressive patterns touches on a little bit of the secrecy that I mentioned earlier, because all trauma is secrecy, right? People don't come with trauma labels on their foreheads. People usually don't talk about their trauma, want to acknowledge their trauma, because it's shameful and embarrassing, and it usually doesn't come up in the average conversation, when you are talking with a friend over mahjong or coffee or tennis, or during a walk. So those repressive patterns of the secrecy, of don't talk about it, that becomes almost an emotional coping mechanism. Don't talk about the stress or trauma, and then it gets generalized to don't talk about any stress or trauma. Let's keep all those emotions a secret. And well, in terms of our emotional health and well-being, we know that not talking about your feelings, right? Because we all have feelings. Not talking about them doesn't make them go away. They just stay there and they linger and hang out sometimes for years until they're able to be let go of. So let's address trauma in diverse populations. So attitude, stigma, and participation in mental health services are unique for multi-ethnic groups, indigenous populations, as well as transgender and gender diverse communities. So there are barriers for these communities, members of these communities, in terms of seeking mental health services. For people of color, seeking mental health services is, it's different. There's mistrust. People of color feel culturally misunderstood. They experience substandard care, disparities in how people of color are treated in healthcare. We're actually seeing that right now in terms of the, unfortunately, the mortality rates as far as effects of the COVID-19. And the the rates of death among African Americans are much, much higher than other groups. And why is that? Well, it probably relates to a number of systemic factors, but certainly differential treatment in healthcare might possibly be one of them. We know that when Black men go to a doctor and say, I have chest pain, they're told on average, go home, take some aspirin, let me know if it keeps up. Whereas when white men go to a doctor and say the exact same thing, more tests are ordered. So there is differential treatment in healthcare. That's a whole nother presentation too. And then there's stigma, negative views towards healthcare, and that's long rooted in a number of things. For some of you, you've learned about the Tuskegee study where African Americans with syphilis went untreated. This was started in the 20s, went on through the 60s, and were not provided with treatment that could have otherwise cured them. For, I think, any group for whom that had happened to, it would be hard to not have negative views towards healthcare, given that that's a part of your cultural history. Indigenous groups also are experiencing some challenges for mental health because they tend to have greater risk factors for interpersonal violence and mental health disorders. Greater rates of alcohol and substance use, and again, there's a number of systemic factors related to that. When you look at communities of Indigenous people, there's probably a lot more access to alcohol than to, say, recreational facilities or health food stores. Childhood trauma and adult revictimization. I always like to clarify this one, that when a child is traumatized, when that happens, and in this case I'm talking specifically about abuse, that abuse is not necessarily repeated. What they have found is that adults who abuse children were more likely to have been abused rather than children who are abused are more likely to abuse. So I think that's a very important distinction, because what that means is not every child who's abused has this stamp of predestiny for abuse later, to conduct abuse and perpetrate abuse later on as an adult. That's not how it works. But among those adults who do abuse, there were higher rates of those people having experienced childhood abuse themselves. Okay, also in Indigenous groups, there's more likely to be teenage marriage, which, getting married at a young age, that can be, well, in some cases, when it's very young, can be traumatic. In other cases, it can be ripe for power and control issues when a bride is much younger than a spouse. And there's lower earning potential for younger women. The data on what women of color can earn, including women in Indigenous groups, in terms of comparison to, say, white males, is dramatically different. And there are also human rights violations that Indigenous populations are experiencing that they're not always talked about every day, but people in those populations are keenly aware of them. And it's a different existence when you know that people in your group are much more likely to be stopped, arrested, detained, charged, or potentially shot by police officers, or when your particular group is disenfranchised for voting. So there's a lot of factors that go into human rights violations for Indigenous groups. Barriers to seeking mental health services among Indigenous groups are the lack of trust. Sometimes it is so Okay, I'm trying to say a lot of things here. When mental health providers are offering services to a community of Indigenous groups, and those mental health providers are all a different ethnicity, as culturally sensitive as they might be, there still can be a lack of trust. So I'm also, I guess, making a case for a strong need for greater diversity among therapists. Diversity makes the population, the field of mental health richer when we can have greater viewpoints. Also, there can be a view that mental illness is a weakness, that mental illness is, you know, it's there's a problem there, you know, the person wasn't strong enough, you know, kind of couldn't fight it off on their own type thing. And that view is not exclusive to Indigenous groups. You see that in a number of other groups as well, but it certainly is pretty strong in Indigenous groups. Often there's also a lack of access to mental health services. That can sometimes be the biggest barrier of all. If someone really wants to go, where are they going to go? If the nearest therapist is 2 hours away for a 45-minute appointment, I think all of us would be, you know, not so inclined to do that. And then there's also the thought of natural healing. Some Indigenous groups, Native Americans being one and others, they believe that healing occurs from kind of from within, that or I should say more specifically within the group, that the healing is something that they can kind of take care of. They might, some of those groups might have what you may have heard of as a medicine man or a healer, and this person might also be a priest. Sometimes it's thought that if there's a mental illness or sometimes even a physical ailment, that there's an issue of sin or something having to do with not having made peace with their deity. And again, that belief is seen in some other religious groups outside of Indigenous groups, but certainly some Indigenous groups subscribe to that viewpoint as well. And it's not, this is not said with any judgment that it's about what is right or wrong to believe. This is just to point out what might make someone from an Indigenous group hesitant to say, oh, you know, I could benefit from talking to a therapist. Barriers to seeking mental health services among sexual minorities. There can be oppressive social pressures to be what you may have heard of as heteronormative. You know, be heterosexual. You know, that's what you're quote unquote supposed to be. Even though we know that's not true, there's no supposed to be of anything regarding one's sexual orientation. But people who have a minority sexual orientation describe it as kind of heteronormativity as being kind of crammed down their throat. There's also transphobia, also homophobia. That should have been on here as well. I left that off. And discrimination. And that leads to concealment of one's stigmatized identity. It's very easy to kind of want to, you know, hide that because of internalized shame. There are distal stressors of political rights. People who are gay and lesbian were only given the rights to marry in just the past few years. Many still have not because they fear coming out and judgment. And there's threats of violence, and people in these groups have had high trauma exposure, especially people of color who are, excuse me, transgender. There's just a higher murder rate for people in those groups in terms of them getting killed, and that's something that they have to live with all the time. People from other groups maybe think about it from time to time, or maybe not at all, but people in that group are keenly aware of it all the time. And even something like, okay, I need to go to the therapist's office, but to get from my neighborhood to their neighborhood using public transportation, I have to go through a neighborhood where 2 other people who were trans like me have been killed in the past 6 months. You know, that's a barrier. That's a literal barrier rooted in fear, which, you know, I think any of us in that situation would be afraid. And the concealment of one's stigmatized identity, that's, you know, that happens more often than we realize because, you know, there are people out in the public eye who have a minority sexual orientation whom we as a society presuppose heteronormativity on them. And that's happened to many people. Lance Bass, the singer in getting my boy bands mixed up, not the Backstreet Boys, but another group, someone else probably knows that. You know, he was he hid his sexual identity of being gay for a long time because, well, think about all the fans he had who presumed him to be heterosexual, because that's kind of the quote unquote quote default. And when it comes to healthcare or mental health care, one of the things that, and this is really, really subtle, is it's about creating a safe space for people of all sexual orientations to feel comfortable. And I had a professor once explain to me that it's about the books you put around you in your office even, or the books you make reference to. Do you put up books that have gay characters in them, where someone who's gay can say, oh my gosh, I've read that book. Or maybe they haven't read it and you can say, I recommend this book to you. It's got a strong gay character as the protagonist. Or even before getting into someone's office, the forms that are filled out. The forms that are filled out, what kind of questions do they ask? Do they ask questions that say things like marital status, single, married, I think it might then say divorced or widowed. Well, for people who are gay, they might not fall into any one of those categories. Someone who's gay might think, well, I have a domestic partner. We are not married, but they are my domestic partner for the past 20 years. So I'm not single, but I'm not married. And just right before they've even finished filling out the form, they already feel like they don't fit, you know, like they don't belong. So when you think about your clients and diversity, that starts from the very beginning of even the way you design your forms. Add a section on there that says domestic partner. Add a section on there that says prefer not to say. And that's okay, because, you know, by showing that you're inclusive in how you even ask questions to learn about your clients, that goes a long way towards letting the client know we're different from the oppressive social pressures of everywhere else. So when it comes to general practitioners and mental health, children with mental disorders are typically seen by primary doctors. And primary care doctors are excellent. I mean, all of us with children take our children to pediatricians without a doubt, but that's different than being a mental health professional. It's not the same. Doctors are very smart, but it's a different skill set. In fact, believe it or not, most children who are prescribed medication for any, excuse me, any type of psychological disorder are prescribed that medication by their general practitioner, which, you know, ideally we'd want to see a psychiatrist prescribing that. So that's, you know, there's more, not, again, doctors are great, but there's more collaboration to be done there, especially when a doctor is making a diagnosis in the office, because not every disorder in an office is going to look the same. So for example, if a doctor sees an ADHD child in an office and says, oh, I don't think they're ADHD at all. Well, that's why ADHD is in fact not diagnosed ever in a one-on-one situation, and every therapist who diagnoses it also wants to hear from the teachers, hear from the parents. What is this child like in non-one-on-one environments? In fact, ADHD tends to not show up in one-on-one situations because the child is going to pay attention to just one person. It's when the child has to differentiate whom to pay attention to in a large classroom, that's when the ADHD kid has a much harder time. So, and most of you are familiar with the Connors rating scale to assess for ADHD that looks at, the teacher's rate, the parent's rate. Sometimes there could be other people involved in the ratings as well. So it's looking at a much bigger picture of the child's functioning. The general practitioner in mental health overall, if the general practitioner finds a mental health, they'll tell the parents, and the parents want those answers, and they have to be able to give the parents answers, but maybe just, make sure you're on mute. But it might not be able to provide the same type of, the pediatrician might not be able to provide the same type of thorough explanation about the disorder, what it is and what it means, that a mental health professional could. Certainly a general practitioner, they might be able to make an accurate diagnosis, or, hopefully, even when they do, how do you explain a diagnosis of autism? It took me a lot of training to be able to deliver a diagnosis of autism to parents with hope, rather than just to say, well, your child has autism. Okay, that's that. But to be able to say, hey, look, there are so many treatment options now. Here's what can be done to help your child function to the best of their abilities. Here are the strengths of your child. Here's what makes your child great. Pediatricians and physicians in general are often not trained in taking a strengths-based approach. It's just not part of their training. Again, doctors have great training. I admire doctors for their training, but it's a very different skill set than what we as mental health professionals are highly trained in. When looking at education in mental health, there's often a gap. Educators need a lot better training in mental health, all the way starting down from early daycare providers. Preschool teachers need to be aware of mental health issues, because undetected mental health issues in children at preschool, they can stay undetected. And then in pre-K and kindergarten and first and on up. And somebody's got to say something. And then until the child is in 5th grade and somebody says, hey, maybe there's something wrong. But then they look back and think, well, maybe the teacher says, I don't know if I should say anything to the parents, because if there was a mental health issue, I'm sure somebody else would have mentioned it along the way. So if nobody else said anything, maybe I'm wrong. You see what I'm saying? So the sooner people become kind of just alert to thinking about, hey, maybe there's something here to pay attention to or help with, then the more people are going to be comfortable identifying it and discussing that with parents, and maybe giving a child an intervention that can save them from a lot of challenges later on. We want childcare workers, when it comes to education and mental health, we want childcare workers and their managers to know about mental health issues, to become more involved with the parents. We want the parents to get to know who's taking care of their children. So for example, are children at a daycare where the daycare providers say things like, as a joke, take a little stuffed toy and say, oh my gosh, this stuffed toy went away, it's hiding in the loony bin. Do they make jokes about mental health issues like that? Even just little, quote unquote, teeny ones, subtle ones. How do they talk about mental health issues? How do they talk about therapy? Would a child care provider be comfortable saying to a parent, hey, I saw a therapist a couple years ago when I had a lot of stuff going on. I was going through something in my family and it really helped me. Just, letting you know that in case you would ever find doing so helpful for yourself. Is that something that ever gets talked about? Is there enough comfort with utilization of mental health services to acknowledge that so many people have benefited from therapy, and that it's a great thing. And I often describe it the same way Irving Yalom did, as the gift of therapy. Therapy is a gift. And do people talk about it as a gift or as a curse? And developing strategies to raise the community's awareness about mental illness in children is helpful as well, because entire communities can be blind to mental health issues. And sometimes it doesn't come up until, unfortunately, it's too hard to ignore. And one way that it comes up is later on as children grow up, and then you start to see suicide attempts or suicide rates in a community as much higher than other communities, and you think, hey, maybe something's going on. And then they say, now let's start talking about it, which of course is a good thing to then talk about it, but ideally you want to talk about it before it gets to that point. And this is, again, taking away that stigma, that shame of mental health issues. So these are our references. I can send those to anyone who would like them. And I will open it up now to questions and answers. I have some of my co-presenters, I believe, on the call, if they would like to offer any answers. Let's see, I know there's a way to get back to, all right, I want to get back to the, where's the, I bet some people have put, I'm unmuting some people, have put things in the chat room, in the chat. Oh, there's chat. Okay. All right. Wait, where'd it go? I lost the chat. Okay. Trying to make this bigger. Oh, okay. Let's do Alt H for chat. It didn't like that. Okay. I don't want to do Alt Q. Okay. All right.
Hi,
Does anyone know how I might find the chat?
Dr. Lisa, if you stop sharing your screen, it should pop up next to you. And then I know the room monitor is supposed to be helping you with the questions, because I do see a couple of them in the chat box. So if you want me to help with that, I can.
Oh, that would be wonderful. Well, thank you. I see them here as well. All right, I'm just going to also unmute everybody for the remaining time that we have here. Okay, so oh my gosh, you guys gave so many comments. This is awesome. Okay. All right, I'm trying to read through and decide what, there's so many, okay. Oh, someone told me as the host, I can mute or unmute everyone with Control M. Okay, well, thank you. Okay. All right, so for me personally, I did not study in children in suburban areas. I agree, Karen, they also have high adverse child experiences score. Trauma is not specific to any certain community. And Angel wanted to clarify that high scores, similar high scores for adverse childhood events occur in inner city as well as outer city, and wanting to make sure that the term inner city does not have overgeneralizations in terms of racial and ethnic makeup of neighborhoods, because you're right, it's about inner city. It could very well be a very diverse group within that city. Within that area. Okay. Are you isolating traumatic experiences to marginalized and lower socioeconomic populations? They are certainly not exclusive to those groups, but what happens is trauma can impact people in lower socioeconomics differently because there's lack of resources. So trauma of, say, a car accident Now that group, maybe that person didn't have insurance. So now they don't have a car. And now they need medical care and mental health care, but they don't have insurance for that either, so they can't access it. Whereas a car accident for someone in an upper socioeconomic group or even in a middle socioeconomic group, that translates into, okay, my insurance, now I have a rental car temporarily, a new car in a week, and I can go to see a doctor and I can go to see a mental health provider if I choose. And so something like that would describe it as a different experience. We also know that people in lower socioeconomic groups experience higher rates of psychosocial stressors. So that, you know, I mean, that was just one example of how what might happen to someone in a lower socioeconomic group for a car accident. But even in just day-to-day stuff, for a woman in a lower socioeconomic group who's a single parent with 3 kids trying to get laundry done, it means you got to pack up all the laundry, all 3 kids on the bus, get bus fare, get laundry money, stay at the laundromat, entertain the kids, you know, fold at the laundromat because otherwise it won't fit on the bus. So you've got to do all that. It's a long day at the laundromat, several hours to get everything done. And on the way home, you're waiting for the bus and now it's starting to rain. I mean, that sounds stressful to me. You know, trying to manage 3 kids in the rain with all your laundry and, you know, waiting for the bus, that sounds kind of stressful. Whereas for most of us who are not in a lower socioeconomic group, you get your laundry, you put it in the washer that's either in your home or apartment, or if you were in an apartment with kind of has a facility in the basement, at least it's in the same building. So it's it's just there are more psychosocial stressors for lower socioeconomic groups, even for the day-to-day things. So, all right, Angel wanted to clarify that theoretical frameworks and interventions have been developed without diverse populations in mind. That's a great point. So there's mistrust of mental health practitioners, but a lack of alliance to meet presenting needs outside of traditional frameworks and interventions. And I know we're getting close to the end here, but I think that point, and that was Angel Brutus, I think that is important because if you have read Michelle Obama's memoir, Becoming, she talks about how her father had multiple sclerosis and how it affected him over the years and how he never saw a doctor for it. And it wasn't clear why, maybe mistrust, maybe, you know, who knows? Maybe because he never saw a doctor in his lifetime who looked like him. Well, he did actually pass from it. And later on in her early career, she worked for the University of Chicago doing community reach with Chicago Hospital to say, look, we've got one of the best hospitals in the country right here. Why is it that we have one of the lowest health rates among residents right here in Chicago? And specifically, she was referring to African in the Chicago community. And so she worked on developing community outreach programs to help medical staff know how to communicate with diverse populations, know how to reach them and communicate with them and connect, and to develop interventions that are not based on just one ethnicity. And I think it's pretty clear that for her, doing that work as an adult is kind of what she wishes that had been done for her own father, because he never got the medical care that he needed. So she developed this entire program and was pretty amazing at it from what it sounds like, that where the sole purpose was to intervene for people in the surrounding Chicago area that were, or right in the city of Chicago, who had fear and mistrust of doctors, most of whom were African American and who were just grossly underserved in terms of healthcare. And she did a lot to change that. So more needs to be done, and it's ongoing. And I'll just leave this as a takeaway point, that the most important thing is to reduce that stigma of mental health. That there's never any shame of therapy. Again, therapy is a gift. Read Irving Yalom's book, The Gift of Therapy, and you know, when someone comes into therapy, it's like you want to say to them, thank you for giving yourself the gift of therapy. I'm here to help with that, because it really, I think it should be seen that way. And I think if everyone viewed it that way, I think that would take a lot of the shame away and increase access for a lot of people of all groups. So I thank you for this presentation, for coming to this presentation, everyone. I tremendously thank my co-presenters who have been so professional and a joy to work with. And I thank you all for your comments, and I'm so sorry. Oh, Lance Bass was in sync. Thank you, I forgot that. I thank you all for your helpful comments and insights, and I wish I could spend a lot more time addressing all of them, but we're out of time for today. So I thank you all. Have a wonderful afternoon.
Thank you so much, Dr. Lisa. We appreciate your help. And I know the room monitor may not be in here, but I just wanted to remind everyone the link for the evaluation is at the bottom of the program that you all received. That's due April 19th. And then if you have any other questions for Lisa, you can either email her directly or email me, and I will CC her on that email, because I know everyone wants all your amazing slides that you just presented to us. So I want to make sure that everyone gets their questions answered, but I know we're on like a super time crunch. So thank you everyone for participating, and we really appreciate your feedback, Dr. Lisa, and your participation in this conference. We really greatly appreciate it.
Thank you so much. I put my email in the chat.
Perfect. And then I'm not entirely sure if you're able to, but if you could save that recording, just because we need it for our records. I'm not sure where the room monitor went, but she's supposed to be helping with that, and I don't have access to that. So,
okay. So I'm going to stop recording. Do you want to stop?